I'm Dawn Orange. I'm a hepatology specialist nurse at York Teaching Hospital NHS Foundation Trust, and I declare I have no conflict of interest. So our poster is entitled A Worthy Lockdown Pastime, and in this presentation I'm going to explain a bit more detail, some background about us, how we were able to complete this project, and most importantly what we found and how we can use it to guide the future service. So I've been working in York for the last 4 years, initially as a viral hepatitis nurse. This quickly expanded to general hepatology. I'm based at York Hospital, but the trust covers an area of around 3,400 square miles with a population of approximately 800,000 people. Like everyone else, when lockdown happened, we had to rethink provision of our service and how we could ensure safe continuity of care without face-to-face review or regular blood tests. Our registrars, and we had 2 at the time, were redeployed onto ward cover, and 2 consultants also increased their ward cover. Therefore, the existing doctor clinics were reconfigured, and those patients were transferred to nurse clinics. Myself and my colleague at the time, Laura, condensed our 5 clinics a week into telephone clinics across just 2.5 days. We retrained for redeployment to cover wards if the call came, which it never did. We had less blood results to review due to the reduction in the samples being taken, so we utilised our time differently. Our priority was to ensure the safe monitoring of patients, and we already had the bare bones of various databases that had been sporadically updated and an established cirrhosis database which overlaps many of them. And this helped when restrictions were lifted because we were able to prioritise the surveillance scans simply enough. Of the other databases, for example PBC and genetic hemochromatosis, we prioritised the autoimmune hepatitis one. So just a little bit to begin with about autoimmune hepatitis. It's an inflammatory liver disease which affects between 10 to 17 people per 100,000, and that's in Europe. We don't have prevalence data in the UK. Causes of autoimmune hepatitis are drug-induced, for example flucloxacillin, viral from hepatitis E, for example, and also genetic dispositions. If left untreated, people can go on to develop cirrhosis and liver failure. It's a condition that will usually require lifelong monitoring, and in about 40% of cases it's diagnosed following acute admission with jaundice. In other cases it's persistent transaminitis of around 6 months, accompanied by hyperglobulinemia and with increased IgG levels found in around 85% of patients. Non-invasive liver screen will be completed, and liver biopsy is essential for confirmatory diagnosis, and this is according to the BSG guidelines. Autoimmune hepatitis can wax and wane, and blood results should be monitored regularly. Patients are usually asymptomatic when transaminitis occurs, and when the symptoms do occur, they're usually non-specific. So the aims of the work, we were all concerned that there would be flares that would go unnoticed. We asked people to stop having blood tests, and we stopped making medication adjustments. For example, we had a patient with suspected autoimmune hepatitis who is only now later in the year about to have a biopsy, and we treated her empirically during lockdown. The higher priority patients were highlighted and had regular phone call checkups, and we know that usually people are asymptomatic with flares, and most patients reported no change or concerns. One patient discontinued azathioprine at the instruction of their GP at the start of lockdown. This was due to low white cell count, which was historic, and if we had had any request for information, we would have been able to advise that we recommend continuing azathioprine. As it happened, she stopped, and I spoke to a regular, and when she did arrange to have blood tests with her GP in June, her ALT was elevated. She restarted the AZA and is now normalised, and her white cell count continues to be low. So we collected data from electronic notes, and it was fairly straightforward if laborious. We did aim to do the IT-based search. We found that this was only finding coded patients who had been inpatients, so this is an ongoing work that we have to do. So we found a total of 128 patients. Since this was completed, we've been consistently updating our database, and we now have nearer 135, I think, and it's safe to say we won't know we've missed anyone until we find them, so that is a worry, but there will be patients historically under the care of the gastroenterology team before hepatology team was established in 2015. So the female to male ratio is roughly 3 to 1, which fits with the literature, and the age range is between 17 to 88 with an average age of 68. So those who have a diagnosis of cirrhosis were already under the HCC cirrhosis surveillance programme. Interestingly, 12 patients didn't have a recorded FibroScan or biopsy, and these were patients either pending confirmation of diagnosis or historic patients who were diagnosed many years ago. So in the context of lockdown with limited blood testing, we had a theoretical discussion in our hepatology MDT around ALT levels and what could possibly indicate inflammatory activity, and we left this in the poster for discussion. I do wonder if anyone has any thoughts or questions for this. To clarify, in patients with advanced liver disease, we argue that an ALT of over 31 for males or 21 for females requires closer monitoring. So as restrictions were lifted, we sent blood request forms to all those who'd not had blood tests taken, concentrating on those results with the recognised trust upper limit of normal. We found that around 25% had increased ALT activity. Not all required any immediate attention, but it's worth noting that that did happen. The geographical data, as in figure 3, was important. As I mentioned before, we cover a wide area. Some of the GP records in these outlying areas are not available to us in York Trust, and vice versa, they can't always get the results that we take in the hospital. Therefore, we often have to chase results which can be time consuming. I think more importantly than that, due to the age demographic of these patients, some of them struggle to travel to clinics from the outlying areas, and those outlying areas would be travelling to Scarborough, and therefore telephone clinics are preferable. We do hold regular clinics in Selby and Malton, and these were re-established fairly swiftly. So what we found from this, no patients missed review while lockdown was enforced. All took place via telephone, and any concerns were swiftly raised and investigated. We had 2 patients with a diagnosis of autoimmune hepatitis admitted to hospital, but this was admission due to comorbidities. Thanks to the database, we had a handy frame of reference when patients phoned for advice, and we kept a close eye with regular phone calls for those we had concerns about prior to lockdown. So we've established that a quarter of patients indicated possible active hepatitis, but none experienced adverse reaction as a result. In the future, we hope to establish nurse-led clinics for ongoing monitoring of non-cirrhotic stable medicated patients, and this is our aim for the future. Thank you for listening.